Hi guys, welcome so much to Dr. Krishnan Lecture. This is a channel dedicated to make learning easy for all the medicos and create an amazing community of super awesome people like you. Regards, CEO and founder of Dr. Krishnan Lecture, Dr. Ramesh Krishnan.
In this lecture video, I will discuss about diagnosis of multiple sclerosis. Now again come to a clinical case. To understand another clinical criteria, a 45-year-old man had noticed a change in his gait in the past 2 years, found that he was not able to lift as much with his left leg at the gym as he did in the past. In addition, he was not able to run or hike the same 10 miles long distance that he did in the past without resting. He was not certain if it has progressed. On examination, he had wrist reflex at the left patella and ankles at 3+ and upgoing plantar response. He had no clear weakness in his left leg, but when he was asked to perform deep knee squat using one leg, he struggles more than he did with his right. MRI of his brain and spine shows numerous periventricular, juxtacortical, infratentorial lesions characteristic of demyelinating disease, as well as 3 lesions in cervical spinal cord. He had CSF-specific oligoclonal bands. So, what is your diagnosis at this point of time? We will come to this case later in our discussion, but first discuss 2017 McDonald criteria for diagnosis of primary progressive multiple sclerosis. It includes 1 year of disability progression, retrospectively or prospectively determined independent of clinical relapse, and 2 of the following criteria should be fulfilled to make the diagnosis of primary progressive multiple sclerosis. 1 or more of the T2 hyperintense lesion characteristic of multiple sclerosis in 1 or more of the following brain regions: periventricular, cortical or juxtacortical or infratentorial, 2 or more T2 hyperintense lesion in the spinal cord, and presence of CSF-specific oligoclonal bands. So this is the criteria for primary progressive multiple sclerosis: 1 year of disability progressions, independent of clinical relapse, and 2 of the following, that is 1 or more of the T2 lesions in 1 or more of the following brain regions, 2 or more of the T2 lesions in the spinal cord, and presence of CSF-specific oligoclonal bands. Now again come to the clinical case that we have discussed in the beginning and apply the diagnostic criteria for primary progressive multiple sclerosis. This patient is having 1 year of disability progressions, independent of clinical relapse. As this patient is having a clinical feature suggestive of neurological disease progression independent of relapse for 1 year, although he was uncertain whether progression has occurred in the past 6 months after the fitness training. So this patient is having 1 year of disability progressions. Now we need 2 of the following features to make the diagnosis of primary progressive multiple sclerosis. As this patient is having MRI of his brain and the spine shows numerous periventricular, juxtacortical, infratentorial lesions suggestive of demyelinating disease. So 1 or more T2 hyperintense lesions in 1 or more of the brain regions is present, fulfilling one of the criteria for primary progressive multiple sclerosis. And this patient is having 3 lesions in the cervical spinal cord, so 2 or more T2 hyperintense lesion in the spinal cord, as well as CSF-specific oligoclonal bands is present. So three of the three criteria for primary progressive multiple sclerosis is fulfilled. So, this was a case of primary progressive multiple sclerosis. Now again come to a clinical case 3. A 32-year-old woman having MRI of her brain shows 5 periventricular, 3 juxtacortical and 2 infratentorial lesions that appear suspicious of demyelinating disease. She denies any prior history of transient neurological symptoms. Additional investigations revealed MRI of her spinal cord and CSF studies revealed single cervical spinal cord lesions that occupies part of the axial cross sections, including segment of the dorsal columns and gray matter. She had CSF-specific oligoclonal bands and a systemic autoimmune workup was negative. Serum vitamin B12 were normal. So, what is your diagnosis at this point of time? We will come to this case later in our discussion, but first let us discuss the diagnostic criteria for radiologically isolated syndrome. It includes presence of incidentally identified CNS white matter anomalies meeting the following MRI criteria, that's MRI lesions should be oval, well circumscribed, homogeneous foci with or without involvement of corpus callosum, T2 hyperintensities measuring greater than 3 mm and fulfilling Workhoff criteria, that is at least 3 of the 4 in decimation in a space, and CNS white matter anomalies. And these lesions should be identified incidentally in the CNS, as well as no historical account for remitting clinical symptoms consistent with neurological dysfunctions. That is, MRI anomalies does not account for clinically apparent impairment in the social, occupational or generalized area of functioning. MRI anomalies that does not due to direct physiological effect of substance, recreational drug abuse or toxic exposures of medical conditions, exclusion of individual with MRI phenotype suggestive of leukorrheusis or extensive white matter pathologies lacking involvement of corpus callosum or CNS MRI anomalies are not better accounted by other disease processes. So, this is the diagnostic criteria for radiologically isolated syndrome. Presence of incidentally identified CNS white matter lesions and no historical account for remitting clinical symptoms consistent with neurological dysfunctions. Now come to the clinical case that we have discussed earlier. As this patient is having MRI findings with 5 periventricular, 3 juxtacorticals, 2 infratentorial lesions suspicious of demyelinating diseases, as well as MRI of a spinal cord also shows the demyelinating events at the dorsal columns. So, this patient fulfills 3 of the 4 Workhoff criteria for decimation in a space, and these are the white matter hyperintensities and were identified incidentally. Therefore, the presence of incidentally identified CNS white matter anomalies was the first criteria for radiologically isolated syndrome. This patient fulfilled the first criteria, as well as she denies any prior history of transient neurological dysfunctions, and no historical account for remitting clinical symptoms consistent with neurological dysfunctions could be explained in these patients. MRI anomalies do not account for the clinical impairments. MRI anomalies are not due to direct physiological effect of substance. Exclusion of individual with MRI phenotype suggestive of leukorrheusis and CNS anomalies not better accounted for by other disease processes were fulfilled in this patient. So, the patient meets the diagnostic criteria for radiologically isolated syndrome, and so this was a case of radiologically isolated syndrome. Thank you.